Hi everyone, welcome to the webinar and happy International Plasma Awareness Week. I'm Brenna Rains, and today I will introduce you to some of PPTA's experts who will go over the basics of plasma, how it's made into life-saving therapies, and its connection to COVID-19. If at any point during the webinar you have questions, please submit them using the Q&A function and not the chat box. We will try to respond to as many as possible. First, a welcome and introduction from PPTA President and CEO, Amy Efantis.
Welcome to our Plasma 101 webinar. We're thrilled that you're able to join us today. And what a great way to kick off International Plasma Awareness Week. So let's learn about plasma. Plasma is the clear, straw-colored liquid portion of blood that remains after the red blood cells, white blood cells, platelets, and other cellular components are removed. When a person has insufficient levels of any one plasma protein, it prevents the body from carrying out vital functions, causing a variety of chronic and life-threatening medical conditions. The plasma from healthy individuals can be manufactured into medicine and given to individuals who lack plasma proteins.
Great, thank you, Amy. Now we will hear from Dr. Joshua Penrod, PPTA's Senior Vice President of Source and International Affairs.
Okay, so let's talk a little bit about how plasma therapies are made. And of course, it starts very much with the donor. And this is one of the things that makes plasma so incredibly unique and all the therapies made from it incredibly unique is that plasma comes from humans. There is no other way to get it. And it's very, very, very important foundational aspect of therapies that are used for all of the necessary and important treatments that we have today. So with plasma being collected, it has a number of steps that are associated with this. And this is a very, very high level overview of what it is like to be a plasma donor and the steps that are taken as far as plasma collection and some of the other things that are attendant to making the plasma protein therapy. So let's begin whenever the donor checks in. And the donor comes into one of the 900 or so plasma centers in the US and the EU. And one of the requirements for donors to check in is that they have an official government ID. There are a number of technological systems that centers use today to confirm identification. There's biometric identification, photographs, and so on. So once the donor's checked in, they move on to make sure that they're eligible to donate. And a lot of the requirements for donor eligibility are a product of both regulatory requirements and a part of the industry standards. We'll get into that a little bit in a couple of minutes. But here are some sampling ideas of eligibility for donors. There's a minimum age. You have to weigh a certain amount. You have to be in good health. I mentioned the identification earlier, but there's also a requirement for a permanent address so that the person wanting to donate could be confirmed to be within a certain defined area of the collection center. And there are a number of other questions on an evaluation questionnaire that the donor has to go through in order to proceed with the donation. But next up, once the donor is done with the screening component or the evaluation component, we move on to the medical screening. This is a medical screening that is designed specifically to make sure that the donor is eligible to donate, both in terms of the safety of the plasma that's going to be donated, but also to make sure that the donor, him or herself, is able to donate without endangering their own health. So this is a medical screening where the doctor looks at a number of physical signs and physical cues to make sure that there's nothing that the donor can be adversely impacted by with the donation. And I want to mention one more thing with regard to the medical screening. There are a number of tests that the donor will undergo as a part of the screening process. This includes things like total protein, hematocrit, and further along down the process as well, the plasma is further tested for infectious disease. Want to make sure that the donor is healthy for purposes of making sure that the plasma is as high quality as possible. And again, importantly, that the donor is not endangering him or herself during the donation, and that they're ready and able to donate without any problems. So once that's done, then the donor moves on to the actual process of the donation itself. And it's a process that's called plasmapheresis. I get asked, or there comes some confusion oftentimes about the similarities between plasma donation and blood donation. And I think a lot of people tend to overlook the differences between the two. But there are similarities, but there are also very, very important differences. And this is one of the most important differences that will become immediately obvious whenever somebody is donating plasma. And plasmapheresis, basically, it means to take something out. And the root pheresis that's what it means. And what we're doing with one of these machines is that we're taking plasma out of the donor, and then we're returning the cellular components to them. So essentially, a person sits down to donate. They have a needle put in their arm. There's a machine that uses a series of tubes and pumps and valves and filters that collects plasma in either a bag or a bottle. And at the same time, the machine goes through cycles in which the red blood cells and the other cellular components are returned to the donor. So what we're left with then at the end of the pheresis procedure itself is a container filled with human plasma that's going to move on in the process. So a little bit more detail on the distinctions between the two. And I think this is important that everybody recognize because, again, we want to make sure that the differences are clear, because a lot of the differences that are there between plasma and blood donation, it changes how a donor is evaluated. It also changes patterns of donation. Because cellular components are returned to the donor during plasma donation, the frequency is greater. So the donor can donate 2 times in a 7-day period with time off between the donations. The length of time that it takes for a donation, for plasma donation, is about an hour. And the average annual donations per donor are about 18 to 20 times per year. As I mentioned, the cellular components are returned to the donor. Now, in blood donation, it's different because the cellular components are taken. That's the entire purpose of a blood donation. The frequency that's allowable in the United States is every 56 days. And the donation duration is somewhat shorter for blood. And because of the need for an increased interval between donations, the average annual donations for a blood donor are significantly lower, about 1 to 2 times per year. So from there, the plasma moves on into plasma manufacturing, and I'm going to talk just a little bit about what happens next with this. Essentially, whenever the plasma is taken from the donor then proceeds out with the exit procedures for the center, and the plasma goes in a different direction. The plasma has samples removed, and the plasma itself is placed in an extremely cold freezer. The maximum temperature of the freezer is minus 20 Celsius. Frequently, those freezers are much colder than that. The plasma is then tested. The samples that were removed are tested. And as a result, the plasma moves on in the process and then goes through the fractionation process and eventual bottling and distribution, with, of course, the fact that the plasma is made sure, or it's ensured that the plasma is consistent in quality and there are no flaws that are discovered with it or anything like that. So only safe plasma goes into the process at any point in time. So picking up on the springboard of a discussion about safety, I think that it's important to emphasize the sophistication, the ability of the industry today to handle a wide variety of necessities to make sure that the plasma is of the highest possible quality and that the donors themselves are taken care of in the best possible way. So, believe it or not, I frequently get asked the question, is the industry regulated? And the answer is yes. There are a number of regulatory agencies that are in place that overlook or oversee the plasma industry. It is a global industry, so there are a number of international and extremely well-respected agencies that have significant and sophisticated regulatory structures that help the industry with quality and safety. And these are agencies that are well known to everyone, like the European Medicines Agency and the FDA, Therapeutic Goods Administration, and many others around the world. But I think that there's another part of this that's very, very important, because it's an emblem of the industry's commitment, ongoing commitment to the safety of plasma, the high quality of plasma, and the safety of the plasma donor. And that's in the PPTA industry standards programs, IQPP and QSIL. So IQPP, the International Quality Plasma Program, is the program that is put over plasma collection itself. There are a number of plasma centers that are, or a number of standards within IQPP that are focused on plasma centers alone. These include things like center appearance, having a professional setting, a certain way that the plasma center appears to the public and to the donor. And other parts of the IQPP program are focused more on the donor, both for safety and quality of the plasma and for safety and quality of the donor. And then the other set of the standards programs, QSIL, the Quality Standards of Excellence, Assurance, and Leadership. This is a set of standards that basically escorts the plasma from plasma donation up through pooling in the fractionation facility itself. And I think that we'll have we can have another discussion at some point in the future on the detail of these standards and the full content of them. But it takes quite a bit of time to go through, because the standards are pretty detailed, and there's a depth and a level of discussion with it that would take up a lot of time here that we don't necessarily have today. But it's also important to know that these standards are publicly available. They're available on our website. The standards come from a completely transparent, open public process, wherein it's open for public comment, just like an FDA regulation or guidance document or anything of that nature. And frequently we go out and solicit public comments according to a schedule where our expert groups within the industry will look at standards for updating and for optimization as time goes on. The standards are administered by PPTA. They're also, the audits themselves are done by third-party auditors that are separate from PPTA and from the industry. So they give an objective review of compliance with the standards. And again, as I mentioned, it's an emblem of the industry's ongoing commitment to patient safety and high quality plasma products. Should also note too that the standards are so well respected that from time to time they are taken on board by regulatory authorities and become a part of the regulatory systems that govern the industry in different jurisdictions all over the world. And back to you, Brenna.
Great, thank you, Josh. Next up, we will hear from PPTA's Senior Director of Federal Affairs, Tom Lilburn.
I'd like to talk a little bit about what makes plasma unique. And in order to do that, let's talk about where we start. So what makes plasma protein unique, one of the major things, is the starting material. It's human tissue. So when we talk about the starting process, we're talking, unlike normal pharmaceuticals who put ingredients together, we have to get a donated material first, and that's human plasma. So that's where we start. The manufacturing process is also unique. Nothing like it in the small molecule world of pharmaceuticals. The safety protocols that go into that are very, very unique too. We're regulated in a number of different areas, unlike pharmaceuticals. And we have a specific different type of value equation for plasma proteins. Donated plasma cannot be made in a laboratory, so we're starting with products that end up being biologic, single source, non-interchangeable, that actually have multiple donations required to make that therapy, unlike small molecules. We have regulation, as I said before, both at the donation site, and then we have regulation by the FDA in the United States at the manufacturing site. So a lot of regulation goes into this, and a lot of oversight. I mentioned before that it takes multiple donations. So, for instance, it takes 130 donations each year to cure or treat one primary immune deficient patient. It takes over 900 donations to treat a patient that has alpha-1 antitrypsin deficiency. And it takes over 1,200 donations in that year to treat a hemophilia patient. So we can see that the magnitude of donations needed in order to treat these patients with these life-saving drugs is quite large. One of the other unique things, unlike small molecule pharmaceuticals, that may take 6 days to manufacture, it takes 7 to 12 months to manufacture plasma protein therapies. A lot of that goes into what Josh was talking about before in the donation process, the freezing, the quarantining, and so on. But the process can take up to 12 months. So it is a very complex manufacturing process, and that adds to the length of the time also. That complex manufacturing process then turns around and can be looked at in terms of cost. 14% of the cost attributed to raw materials in the small molecule pharmaceuticals versus 57% for plasma proteins. So the cost of simply starting the process is far, far higher in the plasma manufacturing than it is in small molecule manufacturing. The other thing are the evolving safety protocols. We have, over the years, developed processes that deal with infectious agents. A good example is Zika. That was something that hadn't been dealt with before, but the processes involved in manufacturing were able to take care of the Zika virus. And we continue to have those evolving safety protocols, again, making this a unique manufacturing process, unlike what's done with small molecules that set their process once and they're pretty much done. With plasma proteins, it evolves. We also talk about value to patients. If we're to consider what we end up contributing to a patient's quality of life and survival, I think this chart is a good example. For the common variable immune deficient patient, which is a very large part of the primary immune deficient community, we've seen a tremendous increase in the 10-year survival rate from 1971, where it was 37%, to now at 2008, where we're over 90%. So for that group of patients, they have seen, with the advent of plasma protein therapies, an entirely new way of life and a great survival. And, you know, we always go back to value to payers because they're involved in this too. The Jeffrey Modell Foundation did a study where they looked at what savings were incorporated when immunoglobulin therapy was used. They found that over $55,000 was saved by treating these patients, diagnosing and treating these patients with IVIG, immunoglobulin. So there is an actual cost savings there. So with that, I'll turn it back to Brenna.
Great, thank you, Tom. Finally, we will hear from Dr. Larissa Chervenikova, PPTA's medical director.
Now we are going to talk about what do plasma therapies treat. Plasma proteins differ by concentration, molecular weight, physical and chemical properties, half-life, or the time they last in blood. This can vary from a few minutes to a few hours, days, or weeks. Only some of these proteins are made into highly specialized therapies, which are primarily used as treatments for persons with rare genetic, chronic, and often life-threatening conditions that require regular injections of medicine for the duration of their lives. Now we will discuss some of these therapies. Immunoglobulins or antibodies are present in blood in high quantities and are an important component of the person's immune system. Antibodies help the body to fight the infections and perform a variety of regulatory functions. This therapeutic class includes normal human polyvalent immunoglobulins and specialty immunoglobulins. Both treat different medical conditions. Normal human immunoglobulins and some specialty immunoglobulins are listed as essential medicines by the World Health Organization. There are two main indications for immunoglobulin therapy based on the mechanism of immunoglobulin action. One is to replace missing or malfunctioning antibodies to prevent infections, and another to regulate hyperactive or out of control immune response. These disease-specific indications for immunoglobulin therapy differ between countries based on the federal, state, local guidelines and recommendations. Normal human immunoglobulins are a standard of care for treatment of primary immune deficiencies with missing or malfunctioning antibodies to prevent recurring infections. This standard of care is recognized globally to treat patients with agammaglobulinemia, hypogammaglobulinemia, common variable immune deficiencies, and a few other antibody deficiencies. There is also a growing number of persons who would benefit from immunoglobulin replacement therapy as well. These patients suffer from so-called secondary antibody deficiencies, which develop as a result of immunosuppressive or specialized therapy used in treatment of cancer patients, or which develop due to infection directly affecting the immune system, like HIV infection. Due to unique function as immunomodulating agent, immunoglobulins are used to control and regulate autoimmune and inflammatory processes in a subset of neurological diseases, such as chronic inflammatory demyelinating polyneuropathy, multifocal motor neuropathy, Guillain-Barré syndrome, and myasthenia gravis. The underlying mechanisms and pathological processes in each condition are somewhat different, but they have one common feature. For unknown reasons, patient immune system starts to produce antibodies directed against protein structures essential for integrity of the neuronal coating or the neuronal cells itself. And this disrupts the function and interactions between the neuron. Immunoglobulin therapy regulates the overreacting immune system in persons with these conditions. Specialty immunoglobulins could be also divided into hyperimmunoglobulins and a very special globulin, which is called raw D globulin. Hyperimmunoglobulins differ from normal human immunoglobulins in one characteristic. They contain high levels of specific antibodies to one specific pathogen. They are produced from plasma of donors who either were naturally exposed to the infectious agent in the past or were vaccinated against one. These therapies are used as a prophylaxis and or treatment of infections such as rabies, tetanus, infections caused by cytomegalovirus, hepatitis B virus, varicella zoster virus, and a few others. Hyperimmunoglobulin against SARS-CoV-2 virus, once made, could be used for COVID-19. There is a special immunoglobulin therapy called raw D globulin or anti-D globulin, which is used to prevent the hemolytic disease of the fetus and newborn. This condition develops as a result of either immunization of a Rh-negative mother with the Rhd antigen of rhesus-positive fetus, usually after the first pregnancy. In the absence of treatment, after the first and with each subsequent Rh mismatch pregnancy, the risk of mother developing the antibodies against the fetal Rh-positive red blood cells increases. If the mother Rh antibodies reach fetus, they destroy the red blood cells, causing various degree of pathology, even death of the fetus. Raw D globulin, given as prophylactic treatment, prevents development of Rh-specific antibodies in mother and protects fetus from being damaged by the mother anti-Rh antibodies. Alpha-1 antitrypsin deficiency is a rare inherited disease characterized by liver and lung abnormalities. In persons with this disease, the liver is not able to produce the alpha-1 proteinase inhibitor in sufficient quantities or release it from the liver cells into the bloodstream. This insufficiency leads to the lung damage by neutrophil elastase, an enzyme which stays under control by alpha-1 proteinase inhibitor in healthy people. Alpha-1 deficiency is a major known genetic risk factor for development of chronic obstructive pulmonary disease. Plasma-derived alpha-1 proteinase inhibitor protects lungs from the damage in affected patients and is lifelong therapy. Plasma-derived C1 esterase inhibitor is used to treat hereditary angioedema, a rare genetic disorder characterized by recurrent, unpredicted, acute attacks of painful, disabling swelling in any part of the body, including the internal organs. The high attack that affects airways is potentially life-threatening because it puts person at risk of suffocation. C1 esterase inhibitor replaces the missing or malfunctioning protein in affected persons. This therapy should be always at the patient's reach and available in emergency situations. Plasma-derived proteins are successfully used to prevent and to control bleeding in persons with bleeding disorders. In these individuals, bleeding occurs because of absence or very low levels of blood clotting factors. If not prevented or treated, the bleeding can be fatal, especially if it takes place in brain or the internal organs. Factor 8 and factor 9 control bleeding in patients with hemophilia A and hemophilia B. Other coagulation factor-specific plasma products help to control bleeding in von Willebrand disease and a few other less known rare bleeding disorders. Albumin is the most abundant protein in human plasma and plays a major role in stabilizing extracellular fluid volume. Albumin helps to keep fluid in the bloodstream and not to leak it into tissues. It also carries substances through the bodies, for example, hormones, vitamins, enzymes, and others. Albumin is used to treat a variety of medical conditions such as it is used in major surgeries, in severe trauma, shock, abdominal infections, certain inflammatory conditions, as well as certain liver diseases, and to treat patients with low level of proteins because of malnutrition. It is used externally to treat burns and for many other purposes as a therapy. Now I'm going to spend a few minutes and talk about how plasma is used or can be used in COVID-19. COVID-19 or coronavirus disease 2019 is a disease which unexpectedly came to our lives this year. With the arrival of this new disease, people have become aware of plasma, maybe the first time in their life, as it is being explored as a treatment for COVID-19. Persons who have been infected with SARS-CoV-2 coronavirus develop specific antibodies against the virus to fight infections. Recovered patients may have different levels of coronavirus-specific antibodies in their blood, from very low to very high. Plasma collected from recovered COVID-19 patients is termed coronavirus convalescent plasma, or CCP. The antibodies which are present in such plasma, when used as a therapy, can block the virus from replicating, they can help clear the virus from the body, and they can activate the immune system to kill the virus. CCP can be used as a stand-alone therapy for transfusion to a few patients, or manufacturing into hyperimmune globulins from large pools of plasma to which many donors contributed. Both therapies contain coronavirus antibodies, but they differ in few aspects. The hyperimmune therapies contain purified antibody in high concentrations. They are standardized and are made by controlled manufacturing processes aimed at inactivation and removal of potential pathogens. Right now, only CCP for transfusion is allowed to be used as a therapy for the treatment of severely affected COVID-19 patients under emergency authorization by the FDA. Several companies work on making COVID-19 hyperimmune globulin therapies. CCP as well as hyperimmune globulin, once produced, can both be considered for pre- and post-exposure prophylactic treatment for persons at high risk for contracting COVID-19, such as healthcare workers, public service staff, individuals with antibody deficiencies, chronic lung diseases, and many other chronic conditions. Indeed, plasma therapies save lives.
Thanks, Larissa. Before we sign off, I'll ask Amy to share an invitation for all of you who are joining us today.
Thank you for joining us for our Plasma 101 webinar. We're thrilled that you were able to join us today, but you can learn even more if you join us for our Global Plasma Summit, a virtual event that will take place October 28th through the 30th. You can register for the GPS on our PPTA website, which is easily accessible by scanning the QR code on the screen here. For today's webinar participants, we have an exciting offer: free registration to attend the first day of our summit. To do so, select Day 1 only as your registration type and use the promo code Day1 2020 at checkout. Thank you.
Thanks, Amy. That concludes today's webinar. Thank you all so much for attending. Any questions we weren't able to respond to today, we will follow up with answers to those by email. We hope to see you all at the Global Plasma Summit. Thanks again, have a great day, and happy International Plasma Awareness Week.